Hello and welcome to our e-poster presentation for GNRS 5301, Pharmacological Principles of Clinical Therapeutics. This is section 1, case study 4 with Dr. Harris, and it discusses diabetes and prescribed beta blockers. Our group consists of Caitlin Avery, Fallon Braden, Tiffany Crochet, Stacy Montihano, and Chantel Johnson. So our case study begins with a 47-year-old female patient who is in for a follow-up visit to monitor her treatment for type 2 diabetes. You added regular insulin to her treatment regimen last month. She tells you that she has not had any symptoms of hypoglycemia with the new plan, and her glucose levels have been between 60 and 80. She tells you that her visit to her cardiologist went well, and she was prescribed a new medication, atenolol, which is a beta blocker. This is Tiffany Crochet. I'll be discussing issues to address with beta blockers in type 2 diabetics. There is a concern that the cardiologist prescribed atenolol, a beta blocker for her hypertension. Beta blockers are not the first line of hypertensive drugs for people with diabetes due to metabolic effects on glucose and insulin. An angiotensin converting enzyme inhibitor and an angiotensin 2 receptor blocker would be better choices. ACE and ARBs have been shown to protect kidney function in patients with diabetic kidney disease. Some other alternative antihypertensive drugs that have proved beneficial choices are diuretics. Lifestyle and healthy diet changes should always be reinforced at each patient visit also. Like I was discussing before, the first line would be ACE inhibitors, second line would be calcium channel blockers, third line would be diuretics, thiazide diuretics, and then fourth line would be aldosterone antagonist. Beta blockers such as atenolol can disguise hypoglycemic episodes in patients with diabetes. Our patient is not showing any symptoms of hypoglycemia because it could be concealed by the start of atenolol. Now Fallon is going to discuss the next topic. Discuss the possible complications when patients with diabetes are treated with beta blockers. As discussed earlier, beta blockers such as atenolol can disguise hypoglycemic episodes in patients with diabetes. Our patient is not showing any symptoms of hypoglycemia because it could be concealed by the start of the atenolol. The patient must be consistent in checking her blood glucose levels at home due to indications that hypoglycemia could be hidden. It also is shown to cause glycemic control to be diminished. Studies show it could increase cardiovascular events in patients with type 2 diabetes also. The increase of the cardiovascular events is due to the numerous hypoglycemic episodes over the time. It would be beneficial for her to contact the cardiologist and voice her concerns about using the beta blocker with her diabetic diagnosis.
As Fallon mentioned, beta blockers can cause hypoglycemia and hyperglycemia in diabetic patients. The mechanism behind hypoglycemia from beta blockers is caused by beta adrenergic stimulation, which enhances insulin. It can also decrease the synthesis of new glucose from non-carbohydrate precursors known as gluconeogenesis, and it can also decrease glycolysis. All of these changes can result in insulin-dependent diabetics to have a decreased response to hypoglycemia. According to Gregory Mills, the article Beta Blockers and Glucose Control, in insulin-independent beta blockers, research has shown that beta blockers can potentially increase blood glucose concentrations and also antagonize the action of oral hypoglycemic drugs, which can result into hyperglycemia. Next, we're going to have Stacy explain the different beta blockers for treatment.
Are certain beta blockers more likely to create problems than others? The short answer to this is yes. Although there's options when it comes to beta blockers for controlling hypertension in individuals with diabetes, there's some that have adverse effects and can be detrimental to them. one of the major side effects could be hypoglycemia, and the individual with diabetes that's put on a beta blocker needs to understand how to monitor for that. There is a quote in Sue and Vetter from 2011 that states non-cardioselective beta blockers such as propranolol are more likely to cause hypoglycemia than cardioselective ones such as atenolol and metoprolol. Nevertheless, patients on the latter, meaning atenolol and metoprolol, should still be cautioned about the potential for drug-induced hypoglycemia.
Next, we have some questions that we would like to ask our fellow classmates in regards to prescribing beta blockers to those with diabetes. First question would be, how do the effects of beta blockers differ for type 1 diabetes and type 2 diabetes? What are the dangers of stopping a beta blocker abruptly? And other than beta blocker induced hypoglycemia, what is another reason that ACE inhibitors and ARBs are better for patients with diabetes? This now concludes our e-poster over Section 1 Case Study 4 regarding diabetes and beta blockers.